Good afternoon. Welcome to Grand Rounds. Today, please remember to sign the attendance log at the back of the auditorium. Also, please remember to fill out and turn in the program evaluations. Please remember to return the audience response cards. And a reminder that we will not be having Grand Rounds next week, the 3rd, or the week after on the 10th. However, today we have a Grand Rounds presentation that I've been looking forward to for some period of time. Today I have the pleasure of introducing Dr. Kasey Strosahl. Dr. Strosahl received her undergraduate education at Simpson and then came to Iowa State where she got a master's in organic chemistry. She got her medical degree from Des Moines University and then did her psychiatric residency at the University of Iowa. She currently is the director of the Psychiatric and Behavioral Health Services here at Mary Greeley Medical Center. And she kindly has agreed to come today and provide us with a presentation on providing psychiatric care via PCP. And please join me in welcoming Dr. Strosahl.
Thank you. All right, so this topic is a very broad topic. It's trying to melt down my whole job into about an hour of what can be provided in primary care. So I have no financial disclosures to make. So psychiatry is not for psychiatrists anymore. It used to be there was a point in time where primary care providers were afraid to treat depression with antidepressants in their offices because it would take away from what psychiatrists were able to do. However, at this point in time, we'll discuss later that there aren't enough psychiatrists around. So a lot of psychiatry is being done in primary care offices. And here's a slide that demonstrates that. It's a list of psychotropic medications. This was for a 1-year period from retail prescriptions filled in 2006 to 2007. As you can see, the yellow is general practitioners, OBGYNs, pediatricians. So they are writing about 60% of psychiatric medications. So the highest of those is anxiolytics, as well as antidepressant medications. Both of those being greater than 60% are prescribed by primary care providers. Where that switches is where you see anti-manic medications, such as mood stabilizers or antipsychotics, and most of those are prescribed by psychiatrists, and rightfully so. We'll discuss that later as well. Stimulants, it's a big mix there. 25% of stimulants are prescribed by pediatricians. So psychiatry in the primary care office. Only 1/3 of Americans with mental health problems receive treatment for their condition. It was thought at one point that all of this was secondary to insurance coverage for mental health services. Before the Affordable Care Act, many insurance companies would not provide any mental health services. It was one way to make insurance more profitable is not to provide mental health coverage or maternity services. So the Mental Health Parity and Addiction Equity Act of 2008 addressed that. The Affordable Care Act, now if you are part of that, it has to provide mental health services, including inpatient and outpatient. But there's still barriers to access, especially for Medicare and Medicaid enrollees. One of the reasons for this, and we see this a lot in the Ames community, is that few mental health care providers are private mental health care providers are willing to accept publicly funded insurance. There's also a shortage of mental health providers. The Parity Act actually exacerbated that problem because the supply of psychiatrists in the United States remained the same, but the demand for those services increased. Primary care providers account for nearly 50% of antidepressant-related visits and 60% or more of first antidepressant scripts. So there's a psychiatrist shortage. I'm sure that's not news to anyone in our community. The lighter areas, which Iowa is one of, are the least, they have the least number of psychiatrists. The numbers from May 2015 is that we have 90 practicing psychiatrists in the state of Iowa. In a period of 19 years, starting 1995 to 2014, the population itself grew 37%. The number of physicians grew by 45%. So the number of total physicians outpaced the population, whereas the number of psychiatrists only increased by 12%. So number of psychiatrists are not keeping up with the growth of the population. In Iowa, 60% of psychiatrists are 55 and older. The average age for that number for physicians in general is 40%. So psychiatrists in general are older than the normal physician age, whereas 55 has been considered an age where physicians like to take less call, they like to work less hours, but that's not necessarily the case. We have psychiatrists in town who don't retire because they feel an obligation to our community. Also in Iowa, I mentioned there are 90 practicing psychiatrists. 2/3 of Iowa's psychiatrists are located in either Polk County, Johnson County, or Lynn County. And also 2/3 of Iowa's counties do not have a practicing psychiatrist. So there are a lot of difficulties in establishing psychiatric care and primary care. So the average primary care visit lasts 13 minutes and addresses 6 patient problems. Mental health problems then compete with other acute physical illnesses, chronic illnesses, and the preventive healthcare services that are provided. Patients who present to psychiatric clinics also have vague somatic complaints usually. They're not going in and saying, I have depression. They're going in and saying, I have headaches, I have constipation, diarrhea, I have abdominal pain, vague physical complaints, fatigue, that a primary care physician has to whittle down into the appropriate diagnosis. There's also a patient reluctance to admit that they have underlying psychiatric issues that are the cause of their physical issues. Only 20 to 30% of patients with mental health issues report them to their provider. So they're not volunteering this information that they're struggling with mental health problems. In a 12-month period, a patient generally visits their primary care provider 1.7 times, whereas patients visit a mental health specialist 7.4 times per year if they have those services. One of the other major difficulties in primary care is establishing a therapeutic alliance. A patient's much less likely to walk in and tell them their whole life story, what they've been struggling with, if they've never met the provider before, if it's considered not the right setting to talk with them. And also, psychiatric offices are generally set up differently than primary care offices. There's not an exam table that you're sitting on talking with a physician. It's usually just a more casual setting with chairs or couches. They're not laying on the couch like people often think that they are, but there are usually comfortable chairs and couches. So we'll go on to talk about the rates of detection of mood and anxiety disorders. It's actually not great. I think in some settings, depending on the education of the providers, it can be better or worse. But people with anxiety disorders are 3 to 5 times more likely than those without anxiety to visit their doctor. And mood and anxiety disorders are often misdiagnosed or undiagnosed or underdiagnosed, leading to self-medication. They're using substances. They're coming in to visit you more for medical problems that are actually psychiatric issues, being treated inappropriately for medical problems when they're actually psychiatric issues, being socially isolated, and not achieving as they could in either their occupation or educational settings. 80% of people with major depressive disorder are treated entirely within the primary care setting. Generalized anxiety disorder, while it's not the most prevalent anxiety disorder, is the most frequent one seen in primary care settings. And there's about the prevalence is twice that in a primary care setting as in the general community. Social anxiety is actually the most prevalent of any anxiety disorder. And those patients are more likely to utilize healthcare services. They're more likely to have depression or substance use problems as well. So studies have indicated that general practitioners recognize mood disorders at only chance levels. So about 50 to 70% of depressive episodes go undiagnosed, and the detection rate for bipolar disorder is about 50%. Social anxiety is detected only 0.5%, whereas we said in the slide before that this is the most common anxiety disorder in the community. So this was a study out of Canada where in a primary care office, MINI, which is the Mini International Neuropsychiatric Interview, was administered. This is a semi-structured interview, which has the reliability as about the same as the SCID, which is the most common used in psychiatric research. So this was administered in the waiting room before a patient's visit with their primary care doctor. And then the medical charts were reviewed for a diagnosis of depression and anxiety then or in the past. So out of the 840 that the MINI was completed on, 27% had major depressive disorder, 11% bipolar disorder, panic disorder around 12%, generalized anxiety disorder was around 30%, and social anxiety disorder 16%, which, except for generalized anxiety disorder, is on par with the prevalence in the community. Misdiagnosis was considered a diagnosis reached during that semi-structured interview, but not documented in the patient's chart. And as you can see there, the misdiagnosis was very high in all of those categories. When they did another iteration of the data, if they found symptoms of insomnia or certain physical complaints like headaches, diarrhea, constipation, fatigue, low energy, those things had sometimes been documented as symptoms in the patient's chart, but a diagnosis wasn't reached in their chart. And that dropped it back down to about 50%, except for in social anxiety disorder, which remained high at about 80%. So what do you need to do to make these numbers better? So the first thing is a complete psychiatric assessment. As I mentioned earlier, that's really difficult with 5 other patient problems in a 13-minute visit. And that's one reason why primary care providers are likely to try to get patients to a mental health provider, is they simply don't have the time to do this complete assessment. So you want to look at the history of present illness. What are their current symptoms? Their past psychiatric history, that includes when did all these symptoms start? Have they been an anxious person, a worrier since they were a little kid? Have they had other episodes? Any hospitalizations for psychiatric reasons, other medications in the past, suicide attempts, etc. Their substance use. I would say one of the questions that I don't know if it's not asked or patients more likely are not answering accurately to their primary care provider is that we see that substance use is much more common in our patients, and they're not being honest with their primary care provider, so it's very hard to treat them. Any relevant social, occupational, or family history. Family history is very indicative of diagnoses, especially for depression. And then a physical exam and other tests to rule out other medical problems that could be causing their symptoms. A safety evaluation. This is talking about thoughts of suicide. Do they have a plan for suicide? Do they have the intent to complete it? Have they purchased the means in order to do this? Another question that sometimes if they have all of those things is, how close have you come to doing this? You know, sometimes when people say they're going to hang themselves, they get all the supplies, they buy it ahead of time, they put the noose around their neck, just to get the feel for it, to know that they can follow through with their plan. Consider other psychiatric symptoms or medical conditions that could increase their likelihood of acting on the suicidal ideas. This could be psychotic symptoms, it could be chronic pain. Command hallucinations are one of the most common that I would consider a huge red flag. Any recent suicidal behaviors, which we discussed above. Potential protective factors. One of the best protective factors is that they have an active social support network. Have they reactivated getting back into the community? Are they talking with family, friends? Do they have coworkers that are involved in their care? Family history of suicides and attempts. Sometimes that can be protective because they see what that effect has caused the rest of their family, but it can also lead them to say, you know, I had a relative that had a very severe depression. They didn't suffer from it anymore after this, and it also indicates very severe depressions in their family. Are they taking care of themselves? Sometimes it's just self-neglect that gets people, so they're not safe to be at home. And do they have children that they should be caring for, but they're no longer caring for? Then after diagnosing a patient, monitoring their progress. So I think earlier the numbers were noted that primary care follow-up is 1.7 times per 12-month period, where a mental health provider sees them 7.4 times. Mental health providers tend to see their patients more often. And during those visits, you're assessing for your adherence to treatment. There's a pejorative context for saying compliance to treatment because we're dictating it and they're supposed to be doing it. So we talk about adherence, and one of the ways that I address this with patients is I ask them how many doses of their medications they miss in a week. I know they're going to miss some, but asking them how many they're missing to make it normalize that. So that way they're being honest with you. You want them to feel like they can trust you and not feel like they're being penalized for telling you the truth. You want to assess for how well their symptoms are controlled and what side effects they're having from their medications. If they're having significant side effects, the less likely they are to take it every day. So these are especially important when they just started on medication. Sometimes when someone is first diagnosed and they start on a medication, if it doesn't start working right away, they feel hopeless, and that can lead to more suicidal thoughts or behaviors. If they're high risk for suicide, they should be in the office at least weekly, if not more often. And if they're not improving clinically, people also give up hope and then think more about suicide. So I started on the medication. It's not working. So what do you need to think about? Like we said before, verifying their adherence or compliance. Are they on the right dose? And we'll talk about that a couple slides in the future. Have they been on the medication long enough? Antidepressants tend to take 4 to 6 weeks for the full benefit of a certain dose. For depression, for anxiety disorders, it's up to 12 weeks. And 12 weeks can be unbearable if you're extremely anxious. Is their diagnosis correct? If you think that there's any question, go back, ask about their prior history and other symptoms, because you could have your diagnosis incorrect, or it could be that there's a comorbid condition that's not being treated. Sometimes we also see that people are doing fairly well, and then their symptoms worsen. So is it that the medications were working, but now they're not? Were they having a placebo effect, et cetera? The placebo effect for psychiatric medications is high. It's around 40%. So adequate antidepressant dosing. The starting dose should be lower than the dose that they need to be on. And that's the titration is based on their tolerability of the medication, and you want to titrate to effectiveness. Wellbutrin's one that the increase is not nearly necessarily based on tolerability. It's more based upon, can I increase it after 4 to 5 days so that way they don't have a seizure if I start them on a high dose to begin with. If they have little response on lower doses, you need to titrate to at least the equivalent therapeutic dose, and then take 4 to 6 weeks on that highest dose before you decide it's not working. So there's a lot of debate about which dose you can say that someone is a non-responder to the medication. Most mental health providers would say you have to be on at least 40 milligrams of fluoxetine in order to have any therapeutic value. I know in milder cases of depression, we can treat with much lower doses, 10 to 20 milligrams, but if you can't say 20 milligrams of fluoxetine isn't working, this isn't a good medication for them. With OCD, up to 100 milligrams is used. I wouldn't recommend that for depression because they will be more anxious. But so this table just demonstrates equivalent dosing to the 40 milligrams of fluoxetine, which is 300 milligrams of bupropion, 30 milligrams of paroxetine, 20 milligrams of escitalopram, 100 milligrams of sertraline, 150 milligrams of venlafaxine, and 45 milligrams of mirtazapine. But I have to say that I don't usually put people on 45 milligrams of mirtazapine because I'm often using it for appetite and sleep as well, and then the lower doses work better. So 7.5 or 15 milligrams are better for sleep and appetite if you're using mirtazapine, especially in elderly folks. So I have my patient in remission, now what? So this is called continuation phase treatment. This is after all of their acute symptoms have resolved. They're now in remission. So the goal here is to prevent relapse. A discontinuation of the medication, which is up to 12 months, will likely result in a relapse of their symptoms. So you need to keep them on medications for at least 6 to 12 months after they're feeling back to their normal selves. So this is same medication, same dose. Don't try and cheat the dose down unless they're really not tolerating the side effects of the medication. So now if they've been on the medication for 12 months, they're completely better. Should you try to discontinue the medication? So I would say unless their stressors are at a minimum, that's not a good time to do it. If there's job changes, moves, children graduating from college, different things, that's probably not a good time to trial discontinuation. Or if they have a history of seasonal affective disorder, fall is not the time to try and trial off a medication. I would wait until spring. The number of episodes of depression also give you an idea of whether it's a good idea to get off medication. If someone has had 2 or more episodes of depression, at least 3 out of 4 of those patients will have a relapse. That relapse could be within a year, it could be 10 years down the road, but there is a risk associated with going off the medications. So generally if someone's had 2, or definitely if they've had 3, I recommend that they stay on an antidepressant medication. Can you just stop the medication cold turkey? This is something that we run into with calls from the emergency department. It's not even necessarily primary care providers all the time. It's often mental health providers that are new to the mental health field. If they're on fluoxetine, you can just stop it. I stopped 80 milligrams of fluoxetine cold turkey in the hospital without any side effects. Fluoxetine gets metabolized to norfluoxetine, which lasts 3 weeks in the body, and so it self-tapers. Any other medication, taper it. Venlafaxine is one that patients most likely are going to complain about if it's stopped abruptly. In the hospital, we can get them off the medications a little bit quicker, but we're seeing them on a daily basis too. So I would recommend decreasing the dose every 3 to 7 days, pending their tolerability. Usually when I start venlafaxine, I start at 75 milligrams, but often when you're trying to get someone off, you have to go down to 37.5. Otherwise, I would say the most common intolerable side effect that people report is they feel like their brain is being zapped, or they describe feeling like they're putting their finger in an electric socket. So the exception to that is if there's a concern for serotonin syndrome. If they have any symptoms of serotonin syndrome, the antidepressant should be stopped abruptly. If you're switching medications, you can do the titration a little quicker. You can get them off, especially if it acts on the same receptors. So when should my patient be referred to someone else? To a specialized outpatient mental health prescriber. Major depressive disorder with psychotic features should be referred to a mental health provider because they will need to be on an antipsychotic, or they will need to be given ECTs to improve their symptoms. If you've been working with them, they've been on several antidepressants that have been at good doses and they're just not responding, then that's another reason to get them into a mental health provider. Same with anxiety. It's my opinion that all patients with bipolar disorder should be seen by a specialized mental health provider. And obviously most providers must agree with that by the prescribing patterns that most anti-manic agents are prescribed by psychiatrists. Schizophrenia also should be managed by a psychiatrist. Other reasons to consider referral is diagnostic uncertainty. If they've been in the hospital several times, we often recommend that they have a specialized mental health prescriber. Or if they just have so many medical concerns that you can't give them adequate time to treat their mental health problems, then they should also have a mental health provider. To a psychotherapist or a counselor, so this is probably one of my soapbox items, is that I don't think enough people are referred to therapy from primary care. Depression and anxiety, their future episodes will be of a less severity if they've learned the skills that they can learn in therapy. Bipolar disorder, most of them have depressive episodes while they're not gaining much insight into while they're manic, they can benefit from the skills that they would learn. There's also a therapy called interpersonal and social rhythm therapy that's done for people with bipolar disorder that helps to regulate their social cycles, their sleep-wake times, just keeping better track of those to prevent episodes or catching them before they get very severe. Schizophrenic patients, they can sometimes benefit from therapy. Often it's therapy regarding residual psychotic symptoms, dealing with hallucinations that they deal with on a daily basis, or just gaining rapport with the mental health system. But also note that the modal, which is the most common number of visits to a therapist, is 1. So most people only go once and then they don't go back. One of the spiels that I give patients is that just because you don't like the provider doesn't mean that therapy isn't for you. There are lots of different personalities out there, and there could be a different therapist that will work for you. It's just that sometimes personalities clash, so you need to try other providers. To the emergency department for psych admission. Active suicidal thoughts, plans mean intent, not a passive death wish. So if they're saying, I'd rather just not wake up in the morning, I'd rather be struck by lightning, something like that. Or if this is chronic, there's no change in it, they've had suicidal thoughts for years, and they know often when things are better or worse. If they can't take care of themselves because of they're not able to get the motivation to get up and eat, if they're just laying in bed for days at a time, etc. Manic, that seems to be the theme on our unit right now. Minimal sleep for several days, elevated, expansive, irritable, flight of ideas, racing thoughts, poor thought processing. The major reason to get these patients in the hospital are because they are very impulsive and they are doing things that can wreck their lives, wreck their marriages, ruin their jobs. And then with mania, you can also have psychotic symptoms, hallucinations, paranoia, or delusional ideas. Psychotic symptoms that pose a risk to their safety or other safety. Command hallucinations. If often we get people in the hospital that will only eat prepackaged foods, so their nutritional supply is quite limited to like cheese, chips, and fruit. Or if they're homicidal. Inpatient psychiatric consultation. If they've had a suicide attempt, if they have, again, active suicidal thoughts, if you're concerned that this is not just delirium, that it could be mania. But mania also doesn't present for the first time when someone's 80. Mental health symptoms are impeding their medical care. So if they are just so apathetic that they're not able to participate in their care, that would be a reason for an inpatient consult. Severe behavioral concerns from delirium that may necessitate antipsychotic treatment, or capacity evaluation based on mental health concerns. So any physician can do a capacity evaluation, and if there's a procedure that's being recommended by a surgeon specialists, etc., they're better able to explain that procedure than I am to know if they understand the risks and benefits. So I'm not necessarily the person to do that, but if there's a concern that dementia, depression, etc., are impairing their ability to make decisions, then we're happy to do those evaluations. And going back, capacity to make decisions and competency are completely different. Competency can only be deemed by a judge, so we are determining their capacity to make a certain decision. Something else that commonly comes up is this bipolar disorder or is this anxiety? Because they can look very similar. So you'll notice there are several things that look very similar there. Things that are different is in mania or hypomania, these patients need less sleep. They're sleeping either 0 hours, 1 hour, up to 4 hours a night, but they don't feel like they need any more sleep than that, and they still have boundless energy. With anxious people, they have difficulty falling asleep. They wake up in the middle of the night, they start thinking, and they can't get back to sleep. But then they feel tired throughout the day. They feel easily fatigued. You'll notice that there's, under mania or hypomania, the decreased concentration and irritability are episodic, but it's sustained with anxiety. So my patient already has a mental health provider. What do I need to do as their primary care provider? So collaboration with mental health services is one of the things that often I think is lost in the mix, and the major thing is communication. So there's not much communication between providers often because they're from different agencies. So medication changes, medical meds can affect psychiatric medications and vice versa. And so those should be communicated. Co-location is one thing that's really popular with mental health services now, and trying to get funding for that is difficult because if you're billing 2 separate visits from the same entity, they both might not get paid for. But that is one thing that has demonstrated improved psychiatric care and improved medical care. Because you'll imagine that my schizophrenic patients don't really like to come to the doctor because they don't like to go anywhere. So, laboratory and metabolic monitoring in those on psychotropic medications. So that should essentially be done by the person that's prescribing it, but that's in our ideal world, and that doesn't always happen. Contraception is also quite important. There's a lot of medications that I would not recommend that people get pregnant on, and it's better if they're planning ahead for children rather than finding out 6 weeks into it, what there's this crisis, do we stop it, do we continue? Often the ones that are most detrimental have already caused the damage that they've caused 6 weeks in, so there's not as much discussion of what to do with the medications. So laboratory monitoring, antipsychotics, and we have a new core measure in psychiatry now. So you probably see more lipid panels on patients. They have to be performed within the year for anyone on antipsychotics if they've been in the hospital. So for BMI and weight, the monitoring should be performed at baseline monthly for 3 months and then quarterly. Hemoglobin A1C, fasting plasma glucose, and fasting lipid panels are what we're having to do in the hospital. They have to be performed baseline after 3 months and then annually. If someone develops diabetes while on an antipsychotic medication, we just follow the ADA guidelines. Then mood stabilizers, getting those lipids at levels at an appropriate interval. Carbamazepine is the one that we use the least in psychiatry. Lithium and Depakote are more of our mainstays. So this I just wanted to share with you. It's a cool resource that I found. It's the Mental Health Gap Action Program. It's mental, neurological, and substance use disorders in non-specialized health settings. It's put out by the World Health Organization, and it addresses a bunch of different problems, a lot of psychiatric diagnoses, but also epilepsy and seizures, developmental disorders. So I just put a few slides of examples of this. It's an algorithm where you're going through based upon what what symptoms you're seeing to make sure that they meet all those criteria. And then if your answer is yes or no, it leads you to the steps of things that you should consider for treatment of the patient. So it gives you all of the diagnoses, the symptoms that you need to have to make a diagnosis of moderate to severe depression and all of the symptoms associated with that, and then making sure that they have difficulties in their social life, because that's always one of the criteria for diagnosing a mental health problem, is that they're having difficulties functioning. And then it leads you to, for depression, psychoeducation, psychosocial stressors, reactivating their social networks, considering antidepressants, etc. It asks also about screening for bipolar disorder. So if you're starting on someone antidepressant, that's one of the first things that you want to do before you prescribe that. I had a patient that was describing to me just an hour ago the first time she was on sertraline, and she describes herself as extremely happy, but in more profane terms, getting a lot done, just more and more done, and losing sleep the longer and longer she was on sertraline. And she does have bipolar disorder. And then it asks about psychotic symptoms, concurrent problems, childbearing age, because that's very important in considering medications, and also if they're under or over 12 years old for adolescents. And it goes through the different interventions as well. So they have the same setup for each of those diagnoses that I listed, and I just thought it was a really unique resource that everyone could benefit from looking through those interventions and just reminding themselves of what's available. So here we have some cases. So these are cases from a study that was done. It was something that was mailed out to primary care doctors, and they had to fill it out and mail back all of the different types of information. So some of this is also informational, not that just that there's a right or wrong answer. So the patient is a 31-year-old man married with 2 young children, presents with muscle and joint discomfort, heart palpitations, and dizziness of more than 1 year duration. Complains of being restless and edgy most of the time, believes that he's losing it because he's constantly apprehensive. His mind races and he can't seem to pin them down. He has come to you because he's concerned that his health is deteriorating to the point that sometimes he has to leave work when the symptoms become intolerable. As well, he has given up many social contacts aside from family and close friends. Shortly after he began to feel this way, he cut back his coffee intake to 1 cup per day. And other than brisk reflexes and a grade 2 murmur, his exam is unremarkable. So I'll have you give your guess out of this differential diagnosis which problem it is. Okay. Well, all right, so 82% said generalized anxiety disorder, 11% hyperthyroidism, and 7% panic disorder or attack. That one is actually generalized anxiety disorder. So this was a list of the physicians were asked to give a differential diagnosis, and greater than, I believe it was between 80 and 85% got generalized anxiety disorder in their differential diagnosis. So the next would be, what would you recommend for a treatment plan for this patient? There's no right or wrong answer for this. It's kind of just getting a feel for what you would do. All right, so pharmacotherapy and counseling. Actually, I was doing these with my husband, who is definitely not a medical person. He's an engineer. And he said that he knew it was that because he said that everyone should get counseling by what I said. So yes, I would recommend pharmacotherapy and counseling. It's obviously interfering with his daily life because at times he's leaving work early. He's coming in with these physical complaints. It is interfering with his life. He's withdrawing from social contacts. So I would recommend both pharmacotherapy and counseling. So now, what kind of pharmacotherapy would you recommend? All right, so we have 48% for an SSRI, followed by 21% SSRI plus a benzodiazepine, 7% benzodiazepine alone, 10% SNRI, and 5% bupropion. The only one that I say I would not do at all is bupropion, because bupropion does not have an indication for anxiety. So it's not, Wellbutrin is not a treatment for anxiety disorders. So often in patients, so the first line of treatment is definitely SSRIs for anxiety disorders. If there is a concurrent reason to start them on an SNRI, if they have chronic pain, that would be a reason to skip to an SNRI before an SSRI. If his anxiety gets bad enough that he is leaving work, sometimes I will use a benzodiazepine to bridge until the SSRI is more at a more therapeutic level in their system. So sometimes I'll prescribe a benzodiazepine for 2 to 3 weeks to get them by until they can get more benefit from an SSRI. But sometimes it can be several months, as we talked about earlier. Anxiety takes up to 12 weeks to respond to medications. Benzodiazepines are a second-line treatment for anxiety disorders. They should not be used as first-line treatment because of their addictive properties. And how soon do you want to see this patient back in clinic? All right, so we have most common answer here is 3 to 4 weeks. 35% said 1 to 2 weeks. Only 2% said 2 to 3 months, and I'm glad that's only 2%. Starting a new medication, this could cause side effects. There are black box warnings on antidepressant medications, so they could cause suicidal thoughts. So you want to follow up a little bit sooner to see if they're tolerating the medication, if they could tolerate a higher dose, because anxiety disorders do take higher doses to respond than depressive disorders do. I would go for 1 to 2 weeks for someone with generalized anxiety disorder. So here's our second case. 42-year-old employed woman married for 21 years with 2 adult children, being seen for a 4-week history of fatigue, insomnia, headache, and abdominal pain. Pain is generalized over the abdomen, constant in nature, denies symptoms or signs of an acute infectious process, and was in relatively good health before the previous month. Intermittent relief from her headache using acetaminophen and takes a multivitamin regularly. She complains food just doesn't taste good anymore. She's finding it harder lately to concentrate at work and to get up the energy to socialize with friends and family. She's reached a point where she wonders if she'll ever feel normal again, yet denies any stress or significant problems in her life. She doesn't smoke and drinks 2 cups of coffee per day. Denies any alcohol intake. So she's tired and has generalized tenderness in her abdomen, but an otherwise unremarkable physical exam. So this one's trickier, but being that we're having a mental health grand rounds, it narrows it down a little bit more. But the differential diagnosis on this one is a bit broader. And I think you could expand that differential even further. But this woman does meet criteria for a major depressive disorder. But these are other things that would need to be ruled out in order to effectively treat her. So what would the treatment plan for her be? All right, pharmacotherapy and counseling. So she's had symptoms for 4 weeks now. It only takes 2 weeks to meet a diagnosis for major depressive disorder. She is deactivating some of her social networks. She was withdrawing. So that's something where a lifestyle change, she could start doing those things. But I do think that pharmacotherapy and counseling is probably the most appropriate for her at this point. If she's never had episodes of depression before, it could be an instance where just going to therapy would be useful. And it depends on, again, the willingness of someone to go to therapy and go more than one time. So what kind of pharmacotherapy? Right, SSRI. And SSRIs are the first line of treatment for depression. Often it's recommended that someone fail 2 SSRIs before they move on to a different type of antidepressant. SNRI, if there are chronic pain complaints, duloxetine, from our perspective, is hard to get covered by insurance if they've not been on other medications or don't have a diagnosis of chronic pain or fibromyalgia. Wellbutrin is not one that I would often choose as first line. One of the side effects of Wellbutrin is increased irritability. So if you have someone that's super irritable to begin with, you're probably going to make them more irritable. But if they're a smoker, sometimes we'll throw it in there. If you want a medication that someone is not going to complain of sexual side effects, that's the one to choose because it's the only one that doesn't have a risk of sexual side effects. And sometimes men are opposed to starting an antidepressant if that's going to be one of the side effects. Mirtazapine, it's not my most commonly used antidepressant medication, but I often use it in elderly folks that have hard time getting enough appetite or sleep because it tends to be more beneficial in those folks. But there is a caution for elderly people on mirtazapine because it does cause orthostatic hypotension. Tricyclic antidepressants also can be valuable, but again, at this point in time, aren't first line. Benzodiazepine, I'm glad no one chose that because that's not going to treat the symptoms that she has. And SSRI plus benzodiazepine, if she was having a lot of anxious, depressive symptoms, that could be useful, but only for a short period of time. So how soon would you have her follow up? Again, 1 to 2 weeks is the most common. If this woman were having suicidal thoughts, I would say 1 week or sooner would be the correct answer, but I think 1 to 2 weeks is appropriate for this. You could stretch it out a little bit longer if you felt like she had good communication with the office staff to let you know if she's having side effects from the medication. So there's the references. Any questions? Situational is best treated with therapy. Mild depressions tend to respond less well to antidepressant medications. So I would say activating their social networks, getting them back into either support groups. NAMI is something that we recommend frequently if they're not willing to go to counseling, or they could do NAMI in addition, or I think counseling is really the key to getting them well if it's a situational depression.
So, thanks for the great talk. The majority of patients that need psychiatric care that I take care of are on Medicaid.
Yes.
So lots of questions in that regard, right? So, I mean, I understand the only option in town would be Early Ball. Is that correct?
Early Ball or CFR.
CFR, okay. And so you mentioned a distinction at one point that refer the patient to counseling as opposed to the psychiatrist, I guess, right? So we just refer to mental health, and then there's a black box there. You know, I presume internally they decide where the patient needs counseling versus.
So often at Early Ball, someone gets an intake appointment, and then they see a therapist first, and if it's felt like they need referred to a prescriber, they will refer them themselves to a prescriber within Early Ball. I would say that one of the detriments in the Ames mental health community is that Early Ball and CFR, aside from Dr. Dodd, who's at CFR, there are no psychiatrists employed by either. So they're seeing a nurse practitioner, and those nurse practitioners are not necessarily psych trained. A lot of them are family practice trained as well. So we're kind of throwing patients in there with providers that don't necessarily have a lot of experience for some of the severe mental health problems that they have.
Okay, well, and the other question I had is we don't often hear back from them. Like, is there any law preventing and that I'm not aware of that we cannot get records? Is there any HIPAA issue? I mean, we often want to see, what happened, and patient often is not able to tell us. And the third question right away, I'm sorry, is any tricks to get people into there? So, the main barrier that we have is people to make their first appointment.
Right. So sometimes with Early Ball, they have a connections program who is someone that they can connect with and will make sure that they get to their first appointment, because getting to that first appointment is sometimes the first step in getting them to the building and establishing that therapeutic alliance. I can't remember this other part of your question. I'm sorry.
Getting records back from them?
So mental health records have to be specifically released. There's a special section on the release of information that mental health, substance abuse, and HIV status, they have to be released. So as long as the patient is willing to sign that, there should be no reason that you can't get records back and forth. Sometimes our issue is we have to go above and beyond the release of information saying it's continuity of care, because it is. But sometimes we have patients that don't want their physicians to know what went on, so they'll specifically say, you can't release my records. So.
I'll take the question. You mentioned about in Epic, in the clinic and the hospital records, certain psychiatric records then are quarantined for only limited access. Who decides what should be quarantined?
That I do not know. I have access to everyone's records, so I'm not sure who determines that. So I know when our patients are marked confidential, and I don't have to break the glass on patients that are here for mental health reasons, but I know the other physicians have to break the glass to say, I've gotten into this patient's chart. It's psychotropic medication monitoring, so it's required. I do think, so that was one of our recent standards that was added to our hospital discharge, is that we get penalized if we don't do that. And I do think it's going to be difficult to get that reimbursed, because sometimes we can't, when the length of stay is short, we can't get all of those records, so we're duplicating work at times, especially, I mean, if they're not a McFarland patient. So we get patients from all over the state of Iowa, so if we get someone from Keokuk, it's not necessarily that we're going to be able to access their records in the amount of time that they're here in the hospital. Yes. If it's only once within a 12-month period.
As far as counseling services here as far as coverage by insurance, private insurance, is that, as I remember, that was always a difficulty for some of our patients. We'd refer them to a psychologist or whatnot, and they had to pay out of pocket for that.
So it depends on the provider. Each provider has a different panel of insurances that they've gone through, that they're willing to jump all of the hoops to see those patients. To my United Healthcare is one that's very difficult in town to find providers that are covered Medicaid, and if it's only Medicare, if they don't have a supplement, often those are Irely Ball and CFR patient referrals. And Dr. Alexander asked earlier about any ways to get people in sooner. I wish we had one, because even from the hospital, it's sometimes a 3-week wait or 4-week wait for us to get them, and they've had an acute psychiatric crisis. So
that intervention algorithms, that looked like good information. How do we find that? Where is the?
it's on my references, but it's through the World Health Organization.
Yeah, it's too small a print, so I couldn't see
Okay.
it. So the World Health Organization, and then what?
I'll have DR List send you the link for it. All right, thank you.